Hi, Emil. Thanks for putting some time aside to chat today. Um, a lot of our ladies talk about worsening headaches or their migraines becoming more frequent in the menopause, and there's nobody better to speak to those ladies than yourself. So they ask the same questions all the time, and I've made a note of them, and I just thought I know someone I can ask about that. So yeah, so thanks for agreeing to answer these lovely questions for most of our clients. Can I just start then with one of the main ones? So what is a migraine? And
So migraine is a neurological condition, and it's where the brain's nerve pathways become oversensitive. And so there's a trigger in the midbrain that sends kind of the wrong signals to the nerves, and they almost like misfire. And so this can then create symptoms, which we are going to go on and discuss. But there can be things like throbbing pain, nausea, sensitivity to light, even a sensitivity to sound or taste or even smell sometimes. So that's the difference. A headache wouldn't.
so what would you say then are the main symptoms of a migraine?
Um, a migraine comes in stages, and the first stage is the prodromal. I can never get that word out. And this can happen about 1 to 2 days before you actually get the migraine. And some people will get mood changes. They could be more irritable, so your family might notice that more than you. You could become incredibly tired. I know my prodromal is yawning. I yawn and yawn and yawn, and I know what's coming. So this can be the first stage, and then the second stage will be the aura. If you're getting an aura, you get the visual changes or the kind of changes to you being dizzy or the head or neck or face or hands. And then you get the kind of pain, unfortunately. And then you get the post migraine horrible feeling like somebody's bruised your brain. That's how I would describe it, is your brain is bruised and it doesn't quite work as efficiently and effectively after a migraine attack. So sometimes the after the migraine bit can be actually worse than the actual migraine.
Yeah, yeah. Are HRT and migraines compatible?
Yes, they are. It is a common misconception that I think it stems from when you have a migraine with aura, you cannot use the combined oral contraceptive pill. And I think this is where that comes from. And it can be, sometimes doctors can get a bit confused with this as well. So the hormone, the body identical hormone that's in the transdermal HRTs, the HRT that goes through your skin, to the spray, the gel, or the patch, this doesn't go through the liver, so it's not increasing your risk of having stroke or a blood clot. It's not increasing your risk of those things. That's therefore it is not a risk to migraine sufferers. Interestingly, the perimenopause is where we see quite a lot of fluctuating hormones. Your estrogen will be kind of low one day, but it could actually peak the next day. And what we tend to see is if you get a migraine without an aura, this is due to a decline in estrogen. But if you get a migraine that has aura, this is due to a peak in estrogen. And this is where the problem is when we use HRT with ladies with migraine, because they will think that everything's going to level out, it's going to be much better, your migraines are going to reduce, and they may reduce. But if you are in the perimenopausal phase and you get a peak, we can keep it nice and steady with the troughs, but if the estrogen peaks, we can't stop that happening. And that's when you can get the kind of migraine incidence going up. And then it becomes more difficult to manage.
Got you. Got you. Okay, I think I've got you. And of course, we probably wouldn't suggest an oral type of HRT for anyone that's got pre-existing health conditions that would increase their risk further
Yeah,
of
yeah,
stroke, for example. Yeah.
yeah,
What
absolutely. We'd be
about,
pushing the transdermal.
yeah, yeah, too right. What about non-treatments like magnesium, CBT? Do they fit into helping our migraines get better?
So we will be looking at the kind of supplements that have some evidence based. Magnesium is one that we would definitely be advising. Magnesium maleate and magnesium glycinate are both quite good, but they can be a bit irritant to the stomach. So obviously be careful with these. And I would definitely use them for at least 3 months just to see if you're getting any benefit from them at all. Um, it's really about
So there's some
lifestyle. So
evidence for those ones.
yeah, there is some evidence to show that they do reduce the frequency of migraines in some people, but it's like anything, everybody's individual, and what works for one person may not work for another. But it's worth giving it a try, but for a minimum of 3 months. It's really about lifestyle migraine. Migraines love change. So obviously they love the perimenopause because there's a change in the hormone levels, but also the associated symptoms that come with the perimenopause and the menopause. So perimenopause can mean you've got poor sleep. It can mean your stress levels could be up because you could be looking after teenagers, you could be looking after your parents. You could be skipping meals as a result of being busy, working full time, trying to pay the bills. But it can be things like you're not eating a good kind of balanced Mediterranean diet, eating lots of good quality vegetables, fruit, getting some protein in your diet. I would be very cautious about using the kind of intermittent fasting if you're a migraine sufferer, because migraines need a nice steady blood sugar. And if you are going a long time without food, this can trigger migraine. So I'd really be careful about doing something that kind of excludes food for a length of time. We don't drink enough. We should all be
It's
drinking 6 to 8
interesting.
glasses of water. So, it's just about, trying to get as much good quality sleep as you can get. And I can sit here and say, oh, get good sleep. We both know that sleep can be quite hard to come by sometimes. And, this morning I've been up since 3:30, which is great. But, I don't want to do that because I could get a migraine as a result of that. But you try telling my head that at 3:15 this morning, I just wasn't sleepy. So,
Yeah.
just try and reduce the kind of things around your sleep time that could interfere with the way you're sleeping. And, reduce your coffee if you do
Yep.
drink coffee. Don't have it after midday. There's lots of things you can do, and this is what we talk about when people come to see us. Nicely
Okay.
done.
Um,
Filled with
is
gin.
there a cure?
Oh, I wish. I wish there was a cure. There is no cure. It's working out what could have been happening to kind of trigger that migraine. So keeping a diary is a really good idea because it can show you possibly if you think something's coming, have a look at what you were doing before that, you kind of started getting that. If I'm starting to yawn, I know it could be tiredness, but if I'm yawning and yawning and yawning, I'll look and think, what have I been doing? Have I eaten? Have I had enough to drink? So it's just trying to kind of write things down so that you can look back and be your own detective. Be careful with migraines because if you are using painkillers regularly, you can create a problem because although they can ease symptoms, they can actually cause more headaches. It's a bit silly. I mean, if you read paracetamol, it says could cause headaches. It sounds ridiculous, but if you are getting them frequently and you are using painkillers, avoid codeine. You want the soluble aspirin. You want aspirin and ibuprofen really, and obviously ibuprofen is all very well, but if you get a migraine and you are sickly with that, you do not want to be taking something that can irritate your stomach if you've got an empty tummy. So if you're getting repeated migraines, and this is kind of more than 4 or 5 a month, I would be definitely going to see your GP and talking to your GP about any treatments that are out there. There's about 9 different triptans now. There was only one when I first started using them about 20 years ago, but now there's about 9. There's a nasal spray one, there's some kind of melt ones. And these, although they're kind of the same type of medication, if one triptan hasn't worked for you, try another one because each one may do something different. It's a bit like HRT. What method works for one may not work for another. So go to your doctor, look at triptans. If you are getting really chronic migraines, and this is kind of more than 15 a month, then you definitely need to be looking at preventative. And there is some ways you can use those triptans as preventative medication as well. But it's a conversation with your GP. So if you've not been diagnosed with migraine, definitely go and speak to your GP, explain your symptoms, write down what you've been suffering with, get a diagnosis. But also, very importantly, if you are using travel insurance and you're going abroad, you need to tell them about your migraines, because there was an incident last year, I think it was, where a lady had a really serious migraine and gone to hospital with it. And I think her insurance company had refused to pay because she hadn't mentioned that she had a history of migraines. So she had to pay for her hospital care. So it's something like that is really important. Yeah.
Okay. Okay, that's good to know. Good information, top tips. So what's next? What can people do next?
Right. So if they are in the perimenopause and they are struggling with migraines and they are not currently on HRT, then if they have no aura and they are under the age of 50 and have no significant kind of risk factors, so their BMI is under 30, they don't smoke, uh, the they've no history of DVT, your blood clots, then they could have a combined oral contraceptive pill taken continuously, because you don't need to have that gap that you have, that pill-free interval causes change. So the likelihood is you'll get a migraine in that 7 days. So take it back to back. If you are older or you don't want to take the oral contraceptive pill, then HRT is a great idea. Obviously, we do this all the time, but HRT, but starting it low and slow. So we want to have, if you start on, say, a patch, it's literally cutting that patch into quarters and starting really slowly. And then if you need to increase your HRT because your menopause symptoms are still being a problem, your flushes are still there and things like that, then we would very gently increase that. You wouldn't go straight up. You would, if you have a 50 microgram patch, you wouldn't whack it up to a 75. You'd be looking at trying to half or quarter that and go up gradually. Another thing I will mention is the different methods that you use. If you aren't struggling with a method that you're using, it's not suitable for you, as in time wise, you can't be waiting for your gel to dry or something like that, or the patches aren't sticking, so you try another method. Be mindful that when you change methods, you may absorb that differently. Even a different patch may absorb differently. And I had this happen recently with a patch going from one patch to another. They gave me a big patch because the Estradot was still out of stock, and I got a really bad migraine. So obviously I absorbed that patch differently, and I cut some off, put it back up, put a new one on, and I was fine. So it's worth bearing that in mind when you're using HRT to try and get on top of your symptoms of menopause, and also help with the migraine to just get you on an even keel with your estrogen.
Amazing. What would I do without you? But when I get patients that email us into the support mailbox and they're maybe struggling with migraines or more and more headaches, and they want to know if we can help, I always suggest that they speak to you, Mel, because I think some people that have experienced it personally are often the better ones with the more experience and the real practical tips that help us day to day.
Yeah.
So thank
Yeah, I wish
you,
I
Mel.
didn't.
I'm sorry that your migraines have been the propelling this talk today, but I'm sure it's helped lots and lots of people. So thank you
Hope
again.
so.
Mel, so just one final thing, just maybe one extra thing that people could tap into for help.
Oh, my go-to is a podcast called Heads Up. It's by the National Migraine Centre, and there's a wonderful doctor called Dr. Katie Monroe, who covers all things migraine. And when she has guests on and things like that, but there's a particular episode called Hormones and Migraine, or something to do with hormones. I remember, but it's really good, and I've listened to it a couple of times because it's really useful advice, and it goes on kind of from puberty onwards and explains about menstrual migraines and why some women unfortunately get these every single month and throughout the
Yeah.
cycle. She's also written a book called Managing Your Migraine by Dr. Katie Monroe. I would be able to hold it up right now, but I've lent it to somebody and I don't know who I've lent it to, so I can't get it back, which is very frustrating. But I would say if you are getting repeated headache, and you are, especially if you're getting visual disturbances as well, but if you haven't had a diagnosis of migraine, go and see your GP as the first port of call. take a list of what's happening, what you're feeling, how often they're happening. The GP needs to know about that because you may need some treatment, but also they may need to rule out other causes. We should never assume it's not just migraine, but we should never assume it's migraine. Just get checked out and also get your eyes tested